Hey everybody, welcome back to the ECG of the day. My name is Reed. Before we get started, go down to the description and download the PDF of this document so you can follow along yourself, make your own notes. And while you're there, feel free to like and subscribe if you enjoy this content. So let's get started. So the first thing I like to do with ECGs is look at the forest, and the trees of the forest are my QRS complexes. So maybe if I pick a lead, maybe here lead 2, I see I've got a narrow complex QRS that seems to be quite regular, until it appears maybe I have a little bit of a gap that occurs there, and that gap is preceded by this beat, which seems to be early. We've got this early beat here that, if you look at the R to R interval, seems to be a little bit shorter when you compare it to the previous R to R interval. So we have this early beat with a pause after, and then if you notice, we just have throughout the rest of the strip the same pattern. We've got what appears to be P waves before our QRSs, and so that's kind of my initial thought of this ECG. So let's go ahead and get into the details. Let's look at the atrial activity. The P wave is our atrial activity, and so we have P waves like we said before QRS complexes. Those P waves appear to be upright in lead 1. They also appear in AVF. We look at this one to be upright as well. So that tells me that these are likely sinus P waves. We know that the sinus node beats at a pretty predictable rate, and so we can determine the rate by maybe looking at a R to R. Maybe this R lands on a solid line, so let's see, 300, 150, 100, 75, 60, just at 60, maybe 59 beats per minute. So technically that's we would call this a bradycardia, right? It's less than 60 beats per minute, but just barely. And so I would say that's pretty normal behavior for what a sinus node would do to kind of drive this rhythm forward. So I'm happy with my sinus node so far. Like we said, it seems like we've got P waves that occur before QRSs. Let's see how those P waves and QRSs are working together, right? And we can look at our PR interval to do that. Our PR interval is what's going to measure the next step in our conduction system after the atria depolarize, which is our AV nodal delay of the signal. So if you pick a lead that's got a nice sharp P wave, maybe here in lead 3, and if you look at the start of this QRS from the beginning of the P wave, you can see the PR interval is maybe 7 small boxes, which is 40 milliseconds per box, and so that's 280 milliseconds, which we would say is too long. So we have an increased PR interval, and which is greater than 200, which are upper limit of normal. And if you notice here, we need to figure out, does every P have a QRS, right? Because at this point we know there is some type of AV block. It's our job to figure out what kind it is. And if you notice, every P wave conducts to a QRS with the same prolonged PR interval. And because of that, this is a first degree AV block. So we figured out how the AV node's doing. Let's look at our QRS, right? And our QRS complexes here, we've got what appears to be a narrow QRS, right? Our QRS here, QRS is less than or just around 120 milliseconds, so I would say that's still narrow, which makes me think it's taking the normal conduction system. My QRS axis is upright in lead 1. It's upright in AVF, which tells me it's going down to the left, and so the QRS axis is normal. That's good. Well, the one thing I did notice, though, if you see here, is we've got this little notching. We've got this little R, and then we've got a little R prime up here in lead 1. So that tells me that there may be some late forces heading towards lead 1, right? If we look at lead 1 is kind of capturing these lateral forces. And so sometimes if this left bundle is just slightly worse than the right, we'll get good AV node conduction down into the right ventricle, and then maybe a little bit slower to the left, and so we get left ventricular depolarization a little bit late and some late forces towards lead 1, and so we actually see that here. But because the QRS hasn't widened completely, this tells us that maybe there is an incomplete left bundle branch, which just means that the left bundle branch isn't completely blocked. It's just mildly diseased. And you can also see here just a little bit more evidence for this left bundle branch block in V1 and V2. We've lost the septal R wave. Usually there's a little R wave there, but we have loss of the septal R. And why does that happen in left bundle branch disease? Well, if I look at my transverse plane here, remember that our right bundle and our left bundle, as they pass through the septum here, the left bundle is actually the bundle that gives off these projections and depolarize the septum from the left to the right. And this is the first aspect of the myocardium that depolarizes. So early in the QRS, in V1 and V2, you get these small upticks in that little small R wave that is in V1 and V2. These are our septal Rs. And so whenever you block the left bundle branch, whenever that left bundle branch becomes diseased and blocked, either incomplete or complete, sometimes you can see the loss of that septal R wave. So that gives us just a little bit more evidence that maybe this is an incomplete left bundle branch block. Alrighty, so we've done that. That explains a little bit of the late transition in the precordium. As we see, it takes till maybe right around V4, V5 for those R waves to become dominant. And so now we've done that, let's take a look at our QT interval. Our QT, I just like to kind of eyeball it. I'll pick two different QRS complexes. I'll draw a line right down the middle, and I see my T wave ends before then, so I know my QT interval is okay. Last thing I'm going to do is look for pathological Q waves and ST and T wave changes, right? We do see that we've got these deep Q waves here in the septal leads of the precordium, so maybe there was a septal infarct. It's hard to tell, right? Is that caused by this incomplete left bundle branch block, or is there these septal Q waves that are caused by a previous septal infarction? Well, if you think about it, right? If the septum is what is giving rise to these left bundle fibers, right? If there was an infarct that occurred through here in the septum, you could, in theory, also have a bit of a left bundle branch block, as the left bundle could have also been a part of that infarction, right? So we got a little bit of double jeopardy here, in the sense that, which one came first? Is this the left bundle? Is this the pathological Q? Regardless, take note and apply that to the clinical scenario. We can also look for ST and T wave changes throughout. I don't see any significant ST or T wave elevations or depressions that are really worrisome. You see a little bit of T wave inversions in the lateral leads here, but that's often caused when you have lateral changes to the ECG. And there's incomplete left bundle branch block is something that is predominantly changed in the lateral leads, right? As the lateral leads are capturing kind of the lateral signal from the myocardium. And so with all of that said, we can now kind of turn to this early beat that we noted and say, well, what is going on? What happened to this early beat? Now that we understand the rhythm and we see the early beat, let's talk about it. First, we can say it's premature. And we know that premature beats are either premature atrial, junctional, or ventricular. And one way to help you find out is that this QRS morphology, the QRS is the same as the baseline QRS, right? You can compare it in all the different leads here. And so with that, we kind of know that it's likely either from the junction or from the atria. And so the reason why I say that is because if you look at, if my QRS complex is the same morphology, it means it's traveling down the exact same conduction pathway as our sinus beats, right? And so in that same incomplete left bundle branch fashion that we already explained. And so now we need to figure out, is this a premature junctional or premature ventricular contraction? And so we need to look in front of this narrow complex QRS, this early beat, to determine, is there an atrial P wave of some sort that can explain why this came early? So what I do is I look, and I don't see anything there, but what I see here is this P wave. And I'll compare it to the previous beat. So a normal QRS like this one, it's got this T wave, and we see we have that T wave here, and then we see this premature beat that is like so. And the P wave of that premature beat does not look the same as our normal P waves when you compare them. So we know that this is likely from somewhere ectopic, right? Because if it was from the same place, it would take the same pathway through the atria and make the same type of wave in the atria. And so you can look at other leads, right? You can look up here at the premature P wave. You can see that P wave that's premature does not look the same as that one. And so what's interesting is that if you look at the P wave that comes early, it conducts here, I'll erase this. You can see that this P wave, it actually conducts with a PR interval that is a little bit longer than our normal PR interval that we have already drawn out. So notice that PR interval is a little bit longer in our premature beat. And that's often seen in premature atrial contractions because the AV node exhibits behavior of something called decremental conduction, which just means that at faster rates, their AV node will actually conduct a little bit slower. And so you see that with premature atrial contractions. And so our diagnosis of this beat is a premature atrial contraction. It's conducted with a little bit of a longer PR interval than our normal, right? And so let's put this all together now that we've kind of done this whole sequence through this ECG. So we've got a sinus rhythm. Sinus rhythm is a rate of 59 beats per minute, so we can call this a sinus bradycardia. We've got a first degree AV block, as well as a incomplete left bundle branch block, potentially pathological QAs of our septum, potentially correlate clinically to a prior septal infarction. And we've got a premature atrial contraction. So, hope this helps. If you have any questions, throw it in the comments. If not, have a great day.